Hi everyone, my name is Vicki Craik and I'm a Public Health Intelligence Advisor on the Drugs team at Public Health Scotland. I'm joining you today from a sunny Edinburgh, and over the course of the next 20 minutes I'm going to talk you through what's on the radar. I'm going to describe how we operate Scotland's drugs early warning system with a particular focus on how we use anecdotal reporting. To start, I'm going to jump in at the deep end. Scotland is in the middle of a drug death crisis. For the last 5 years, we've had more than 1,000 deaths per year. Because of this, we've declared a public health emergency and launched a national drugs mission. The death rate in Scotland is currently 14 times higher than the European average. Now, there's a number of factors that are contributing to that crisis, but the one that we're going to focus on today is drug trends and changes to the drugs market. This chart here shows the percentages of Scottish deaths broken down by drug or drug type. We can see that the overall numbers add up to more than 100% because we have a real issue with polydrug use, so taking more than one drug at a time. We have high levels of background opioid use. We have escalating levels of gabapentinoid and cocaine use. And this blue band here shows a real rise in the use of street benzos. Street benzos is a term used to describe benzodiazepines that aren't licensed for medical use in the UK. You can see this rise really started in 2015, and it was at this time that I was working in drug services and we started to get reports from people who were taking drugs that they were taking street valleys or blues. We weren't entirely sure what they were at the time, but they were causing adverse effects, overdoses and deaths. The reports were coming to us ad hoc, and we tried to collate them and escalate them nationally. And one of the responses we got to that will always stick with me was, "Aye, but that's just anecdotal." And our reports and our concerns weren't taken as seriously as they should have. Between January 15, when we started getting these reports, and August 2016, when we published the national drug death data for the previous year, over 200 people had already died from street benzos. So by the time that we had official accredited data and were therefore able to respond, we were already way behind the curve. That meant that when I had the opportunity to create a drugs early warning system in the country, that those anecdotal reports would be a key part of the system. So that opportunity came in June 2022 when we launched RADAR as part of the Scottish Government's National Mission on Drug Deaths. RADAR stands for Rapid Action Drug Alerts and Response, and it's a drugs early warning system that collects data from a range of different sources. It validates, assesses it, and then communicates that regularly with our partners and the public in order to reduce drug-related harm. It was a collaborative effort to launch RADAR, and when we were designing the system, we wanted it to have a few key characteristics. So it had to be trusted. People had to trust us with them sending us pretty sensitive information and reports, and that we were going to use that information sensibly and for health purposes. So we came up with a look and feel that was recognisable. It also had to be accessible, and by that we mean that anyone can make a drug report to us. If you're concerned about drug use in your area, you can send us that information. Also, anyone can join our network. You don't have to be a worker or a professional or already tied into the service. You sign up for our network, be part of our mailing list, and get alerts as soon as they come out. It also had to be accessible back out the way, so we publish as much as we can on a 12-week basis through our dashboard and our quarterly report. And another non-negotiable key characteristic was that it was multi-agency. This system is managed and coordinated by Public Health Scotland, but we couldn't do it without the collective effort of hundreds of people across Scotland. So I can't take credit for these slides, and a huge thank you to everyone who has supported us. To create RADAR, we had to do two key things. We had to improve our existing data and then collect new data. We already had a wealth of really good, high quality data in Scotland, but the majority of that was published on an annual basis, far after the harms had occurred. So what we did is we looked at all our data sets and we thought, how quickly can we get these out here? By publishing it as accredited statistics, it takes a long time, but it comes with a high degree of quality and certainty. So what we decided to do is all the data sets here, hospitalisations, toxicology, naloxone incidents, we now get that data in and we publish it every 12 weeks. It's less quality assured, it's less certain, but it still gives us a good enough indication and as real time as possible. What we also did is we implemented this bottom part of the pyramid. This is our anecdotal reporting. We call this active data because it's coming to us in as real time as possible. And that's reports that people can send us from services, communities in their homes. We do this in two key ways. We have our reporting form and our mailbox, but we also have the opportunity to reach out to our network of 700 people in services, ask them any questions that we might have, and also send them enhanced surveillance surveys if needed. All information that comes to us goes through this 4-step process. So we receive the report in, say from our mailbox. We then add that to our log, our central drug database. If that report shows that there's significant ongoing levels of harm, we would escalate that internally. Then what we would do is we would add some context to that report. We would assess whether we think the report is valid, is it an issue that we're seeing in other areas, are we getting other similar reports? We would pull together that context and then we would send it to the distribution list for key contacts in that health board. So internally, if it's a routine report, we would continue to monitor and assess it and see if we were getting any other similar reports. Locally, they would add that to their information collection systems and, if appropriate, share with their local groups. If it shows a significant level of harm, they might want to convene a local problem assessment group in order to inform the response. And then Radar communicates out all information in these key ways. If there is a national threat to public health, we would put out an alert. This is on the rare occurrence. We've only done this 3 times in the last 2 years. It might be something that we respond to by putting out new resources or guidance documents. We might share the information at local groups and meetings and conferences, and regularly, every 12 weeks, we put it out on our dashboard. This allows people to go into our harm and service indicators. They can see the national picture, how that compares with the year before and the previous quarter. They can download the data and they can also filter it by time period and their health board area, so people can see what's happening to the harm levels where they live. It's on this dashboard that we also publish all those anecdotal reports that we receive through this Intelligence Reports tab. We don't just kind of copy and paste the report in as we receive it. The reports can be a little bit messy, so we put it into our data set. What was the area? What were the primary drugs in appearance? We also generalise it and we remove any identifiable information, and then we shorten it and pull out the key messages. So again, people can go on, they can filter by drug, time period in their area to see what's trending. To make it as easy as possible, we might have received 50 reports in that quarter. We pull together a trends section in our quarterly report. What this does is we've received 50 reports between January and March. Here is the most common drugs that are being reported, and out of all those reports, we have a key concern about synthetic drugs in circulation. So here's some information and resources and what you need to know. So one report by itself is just anecdotal, but when you're able to pull together hundreds of reports from across Scotland, key patterns start to emerge. Since we launched, we got our first report in July 2022, and we've received over 400 reports. The majority of them are already available on our dashboard, so you can go away and look at that after. We're currently processing about 50 because we've had a really busy couple of weeks. And occasionally we'll choose not to publish a report. This could be because there's just not enough context, or the report doesn't make sense. Maybe it's something that we have to investigate a little bit more of before sharing wider. And we also choose not to put on reports that have come to us from social media. If something's trending on a local Facebook group or on a Snapchat, we don't really want to buy into that. It often lacks credibility and it distracts from the wider issues at hand. You can see that reports to us are increasing, which is great. It gives us a really rich intelligence picture, and that's just as the system becomes more well known. Confidence is also growing because what we do is very accessible and transparent. People can see that we're not just hoarding these reports, that we are putting them back out there in the public for a benefit. They can also be confident that we're actioning the reports. So if somebody reports that there's a drug harm cluster in their area, we will then link directly in with the health leads in that area to take action. It doesn't come out without its challenges though. One of them is it's perceived as being unscientific, and sometimes reports can come to us and they'll lack structure or details. We try to get around that where possible by encouraging use of our reporting form. The system that we use to capture reports is called REDCap, and it provides a consistent way of sending us reports. It's a short, quick, easy form. It will only take a couple of minutes. People have the option to leave their email address if they wish, but they don't have to, and it can be anonymous, and we do not collect IP addresses. We ask them a set of closed questions to get the answers that we would need to then further communicate or escalate the issue. So what happened? Where did it happen? When did it happen? What drugs were involved? What did they look like? Where were they sourced? There's also an option for people to upload testing results or drug photographs, and there is one open text box at the end where people can add further information that's not already been gathered. So the reports can be somewhat unscientific, but by using these consistent data capture methods, it does provide a valuable data set. Any report that comes to us, whether that's via the form or our mailbox, is added to our database as well to create a data set, and that helps us to quantify the trends. This chart here shows the reports to Radar over each quarter since launch. The majority of reports that we get are for adverse effects, overdose and deaths, and the majority of reports that we get come from frontline workers. It shows that our key drugs of concern in Scotland, it's no surprise to us that it's cocaine and benzos, but one of the valuable things of this is it's shown in early 2023 that people's concerns around the heroin supply started to grow. This other category, this teal box, our other main drugs are ketamine, MDMA, pregabalin and gabapentin, painkillers like tapentadol. And I also looked at the database just before this presentation. We've only ever had 3 reports of methamphetamine, which shows our stimulant market is really dominated by cocaine at the minute. Another challenge we get is the information. It can be difficult to represent entire populations or draw conclusions from some of it, and we're careful not to generalise. So before we take any action from a report, what we do is look at the wider context. We look at our toxicology, our harms and our service data, and we see if we can identify anything else that's going on. It's also subject to bias. So if we put out an alert for a drug, we're more likely to get reports of harms about that drug. So we have to be conscious if what we are communicating out there is influencing the trends that we're receiving. They're often biased towards getting more reports amongst young people because there's a higher level of concern there. And then we often get more reports if the report is a bit interesting or novel rather than representative of the harms. So we have to be aware of this, and before we send any report onto the local area, we had this little box on context. We could say this is the first report that we've had of this drug or this type of concern. It's not something that we're currently concerned about, but here's the information. Or it could be this is the fifth report that we've had of this concern this week. It's coming to us from all areas of Scotland, and we think that this is an escalating situation. Here's some more context and reports. But there's also a huge amount of opportunity that these reports give to us. The main one being that it just comes to us really quickly. They can be reported to us as the trends are happening, or quite quickly after. One example is a few months ago, we got a report from a hospital that they had patients presenting with liver failure after taking anabolic steroids. We pulled to get that information, we sent it to the local areas, and the local areas said to us, this is something that we're concerned about, we've not had before, and it's unusual to get these effects from steroids. We were able to then link them in with the hospital, who were able to link them in with the family who were still in possession of the drugs. This meant that quickly we could get pictures and testing data that shown in this situation the steroid was what it said on the tin. But unusually these were 50 milligram pills and an average dose was expected to be 10 milligrams, so they were a dangerously dosed tablet. We were able to then quickly go to our steroid clinics and make sure that information was getting out to the people that needed it. Another example happened earlier on this year. So we've been working with the ambulance service to encourage their crews to report unusual situations to us. So it might not show up in data, but if they think it's out of the norm. That happened in March 2024 when the ambulance crews had attended 4 overdoses in one city. That isn't unusual, but 3 of the patients had died by the time the ambulance service had got there, indicating a rapid deterioration. We immediately escalated that internally and we phoned our key contacts in the area. That afternoon, Friday afternoon, we were able to send an alert to local drug services, health services, homeless accommodation providers to let them know about this drug harm cluster. We also informed colleagues in the police, and the ambulance crews were able to put a message on their control panels indicating this unusual cluster that was ongoing. The situation continued over the weekend, where we had 10 deaths over that weekend, and it did continue into the following week. But by receiving that report on the Friday afternoon as it started, we were able to alert people to take action, which hopefully saved lives. Another key opportunity is that it identifies the research. We're a very small team at Public Health. We've got limited resources, and these reports gives us clues on what to focus on. When we first started, the reports of benzos that we were getting in was that they were having different effects. They were still benzos, but they weren't the same benzos that they had before. They were causing extreme sedation. We were then able to take these reports, go to our toxicology providers and see, is there anything unusual in toxicology that could be causing this change in the market? That identified that there had been a little increase in what we're calling bromazolam. Bromazolam is a traditional sedating benzodiazepine. We were able to go to all our tox providers, make sure they were testing for bromazolam, and subsequently we saw a big increase over the next year of bromazolam showing up in our post-mortem. So this meant at a very early opportunity, we were able to take these reports, verify them through our toxicology, and put in information out through our network, our quarterly reports, and subsequently we published a national public health threat alerting about these new changes to the street benzo supply. We had a similar situation last year where people started to report that there was something wrong with the heroin. It was cut with something bad, it wasn't reacting, it tasted or smelt differently than what people would expect. We looked at the toxicology data and that didn't show us much, but we were able to go to the Scottish Needle Exchange Workers Forum. We told them about our concerns and about these reports that we were getting. They were able to get samples from their clients and send that away for testing. And that has shown that there was something wrong with the heroin. The drugs were sold as heroin, they contained heroin, but they were also detecting xylazine, nitazenes, or both. And like previously, we were able to send that information out to our network, publish it in our quarterly reports, and put out an alert once we had that evidence that was initially triggered from these anecdotal reports. And finally, one of the key opportunities is that it humanises the situation. We can be too engrossed with dots and lines on charts and it doesn't really show the devastating reality of the harms and deaths that are happening. These reports do. They provide a face behind the reports, and they give a personal story to help our understanding. So I used to see of it as being like a spectrum where you had this really good gold standard accredited data at one side, and then this messy, less credible data at the other. But after 2 years, my views changed, and now these anecdotal reports, I view them as being the heart of the system, and they're not any less credible than the other data that we get, and each piece of data forms a valuable piece of the puzzle. I am now out of time, so I will stop there, but thank you so much for giving me the opportunity to present at your event. I hope you find it was useful, and you're more than welcome to follow up with any questions or queries that you might have at these email addresses. Also, all the alerts, resources and reports that I mentioned are publicly available at publichealthscotland.scot/radar. Thank you.